Hey guys, Dr. Ash here, coming to you to talk today about childhood disorders. All right, so here's the deal. This is by no means all inclusive. Hear me again. This is no means all inclusive. There are many, many more childhood disorders. However, these tend to be your heavy hitters, ones that are most commonly tested on, ones that are most commonly on your NCLEX. So let's go ahead and get started. Again, down and dirty version, so you don't have to read a ton in your books to understand what these are about. So let's go ahead and get started. So first one, and this is extremely common, is otitis media, and that's basically just a middle ear infection or inflammation. Basically, babies and small children, they have eustachian tubes that are short, wide, and straight, which makes them perfect candidates to get blocked and or have drainage kind of going into that ear canal. And so basically what happens is it builds up, it causes inflammation or infection, commonly seen after an upper respiratory infection like RSV, flu, bronchitis, just a typical runny nose. Truly anything after a respiratory infection is where you can commonly see otitis media. Now, how do we prevent it? We tell people to feed upright. And this is important because I see oftentimes, oh gosh, I see it on social media too, and it drives me crazy. But people like to put their baby to bed with a bottle, and that is one of the worst things you can do because they do have that short, straight eustachian tube. Anything that they don't swallow immediately can back up into the ears. And so feeding in an upright position only. Routine immunizations is what I should say. Of course, we encourage breastfeeding for the first 6 months, if at all possible. And then really the biggest thing is tobacco smoke. Tobacco smoke and allergens tend to inflame these little bitty eustachian tubes. And when they become inflamed, they can become infected. So tobacco smoke is the number one way to avoid or prevent otitis media. Assessment, you're going to notice these babies have fever, ear pain, they're very irritable, they may have loss of appetite or poor feeding, they begin to tug or pull at their ear, and you may even see purulent drainage on the pillow after sleep, or it could actively come out during the day as well. Interventions, of course, we want to encourage fluid because we want those babies to stay hydrated. We want to lie with the affected ear down. That would actually promote drainage. So laying on the affected ear, complete antibiotics, full course of antibiotics. You have to complete antibiotics, y'all. This is really important in children. You can take your own life in your hands by not finishing your antibiotics, but please let your children complete their whole course. And then we can also add benzocaine eardrops, and that's just to help with pain relief. So again, just very basic, but exactly what you need to know about otitis media. Conjunctivitis or pink eye, this is inflammation or infection of the conjunctiva or conjunctiva. Contrary to popular belief, this does not come from gas on your pillow. So I have boys in my house and they're like, I'm going to give you pink eye. I'm going to fart on your pillow, but that's not the case at all. It can be caused by an allergy or like pollen in the eye, or it can be an infection, or it can be based on trauma. Those eyeballs are really sensitive little creatures. So what you find on assessment is maybe itchy, scratchy, burning eyes, redness. They may be swollen, and they may have discharge or drainage. Oftentimes people actually, their first complaint is they wake up with their eye crusted over in the morning. So interventions, of course, if you get an antibiotic, please finish all the medication. Hand washing. Conjunctivitis is extremely contagious. So lots and lots of hand washing. Don't share towels, don't share linens, don't share clothing, none of that. You want to avoid hands in the eyes because that's how it spreads. No contact lenses for our older children. Because the contact lenses can become infected. You use them again after you've cleared up the infection, and guess what you get again? You get the infection again. For our teenage population, females or males that choose to wear eye makeup, it's got to go. So eyeliner, mascara, eyeshadow, all of that has to be discarded because it can potentially harbor that bacteria. The next one is sudden infant death syndrome, also known as SIDS. This is basically an unexpected death of what appears to be an otherwise healthy infant, usually less than a year of age. So we have a lot of theories on what happens in SIDS, and The true cause is unknown, although I will tell you that I recently learned to a trip to LA that some other countries have done studies and have actually found a genetic defect in our SIDS babies. However, in the US, we don't make a habit of doing research on children or pregnant women. So a little bit harder to find here. However, there are some things that kind of back up when most of these happen. So during sleep, but not necessarily at night, we know babies take naps throughout the day, more likely in the winter months. At age 2 to 3 months, it's more likely. Boys have a higher risk than girls. Native American, African American, Hispanic, and low socioeconomic higher than other populations. Some high risk behaviors that happen: prone positioning, so having them laying on their bellies in their crib, soft, fluffy bedding, stuffed animals, anything oversized, like oversized couch cushions, anything soft where their face can kind of be buried in that soft, fluffy material. Overheating, believe it or not, having that baby too hot at night can cause SIDS. Co-sleeping, plenty of stories out there of babies being rolled over on, or the cat laying on their face because the cat sleeps in the bed with them. So lots of horror stories around co-bedding. And then exposure to cigarette smoke, again, inflames the airways, makes them even smaller than what they already are, puts them at high risk for SIDS. So interventions, we have this thing called Back to Sleep. It was a campaign that started in 1994, and we are still doing it. So back to sleep just means a supine position for sleeping. The problem is it causes something called plagocephaly, and that just means a flat head. So these newborns very early on tend to have bald spots and flat backs of their heads from where they lay on their back. We also want to avoid high-risk situations. So all those things we just talked about: cigarette smoke, fluffy bedding, stuffed animals, prone position, all those things we want to avoid, co-bedding. And then we want to provide tummy time. And this tummy time basically means, or tummy time only when they're awake. And that basically means we're putting them on their belly to give them an opportunity to develop their head and neck muscles. So one of the things behind SIDS is the reason why we don't do fluffy bedding and stuffed animals and couch cushions is because they don't have this strength in their head to turn away when they're being suffocated. So giving them lots of tummy time will help develop that head and neck. If death occurs, which sadly it does sometimes, don't forget your therapeutic communication. We don't blame, we don't project. We want to make sure we're empathetic, we are understanding of their feelings. And then also very, very important is that we do follow-up home visits very soon after death, because again, death of a child, very high stress, high risk situation, violence will occur in the house. So we have to do a home visit pretty soon after the death of the child. Next, we'll move on to CP, cerebral or cerebral palsy, just depends on where you're from as to how you say it. This is impaired movement and posture totally of the motor neuron system. We have several different types. We have spastic, athetoid, ataxic, and mixed. However, spastic happens to be our most common and affects the upper motor neurons. Assessment that you're going to find: as they're a baby, they're going to be extremely irritable and you just can't figure out why. They may have difficulty with feeding, abnormal movements. Their muscle tone may be stiff or rigid. As they get older, we notice that they may have seizure activity or the primitive reflexes. If you watch the newborn care, we talked about Babinski and sucking, rooting, and swallowing, startle, and Moro reflex. These reflexes are supposed to disappear as the child gets older. These are called our primitive reflexes, which mean they are like our basic primary way to function in life, right? The startle keeps you safe. The sucking, rooting and sucking and swallowing reflex helps you stay hydrated. So these are primitive reflexes. We find in our CP kids, those kind of linger. They stay around even when they're not supposed to. So interventions, the biggest intervention, y'all, if you don't hear anything else, hear me now. The biggest intervention is early recognition, so we can maximize their abilities and minimize their disabilities. And what that means is we get speech and physical and occupational therapy actively involved from the start so we can prevent disability or prevent further disability and maximize their ability. Most of these children are very intellectually intact. It's just their poor little bodies that don't work. So we definitely want to encourage participation in school and social activities because we want these children to socialize. We want other children to be comfortable around them. We want them to be comfortable. The only other thing to say about CP is we need to make sure that they are age appropriate toys and they have safe environments. Because of that motor neuron impairment, they are high risk for falls, high risk to injure themselves. So we have to provide a very safe environment. Attention deficit hyperactivity disorder, or ADHD. This is specifically a behavioral disorder where the child is not appropriate in their attention span, their activity level, and their impulsivity, which means they just don't really think about it. They just kind of do whatever it is that they want to do. This is often accompanied by a lower intellectual development, physical impairment, sleep disturbances. They may have behavioral or emotional outbursts, and they may be very uncomfortable or very difficult in a social situation. So common assessment findings, they're very fidgety, constantly on the move, they're easily distracted, poor attention span, they really do not do well with instruction, and they usually have lots of unfinished projects. So they start something, but then they can't finish it. Excessively talking, interrupts others, doesn't care if somebody else has an opinion, and they can engage in physically dangerous activities. And again, that kind of comes hand in hand with the impulsivity that we talked about. So how do we treatment? It's usually a combination of all of these things. So some sort of behavioral modification or behavioral therapy, medications. Most of these are stimulants like Ritalin, or it's really kind of funny because they start with methylphenidate, very similar to methamphetamines, but on a safer, supposedly safer path. But stimulants can cause weight loss, loss of appetite, difficulty sleeping, and elevation in blood pressure and other vital signs. The other thing with our ADHD kids is we have to be very consistent. So whatever the behavioral therapy recommends, that should be happening in the school as well as at home. Visits to grandma, we got to really stay consistent because otherwise this behavior can kind of spiral out of control. And then we want to promote self-esteem because, of course, this is the child that's on medications. They're going to see a therapist. They're doing all the things, and they may get picked on. So we want to make sure we promote self-esteem. Autism spectrum disorder. Autism is such a wide variety these days, far different from when it was diagnosed when I was learning about autism. So autism, very broad. We are not interested in you knowing every single piece of the spectrum. We want generalization. So we're just going to talk in a very general term when we talk about autism. Just remember, as you work through the autism stuff, some are more severe, some are less severe, some are high functioning, some are low functioning, but just in general, this is what we're going to find. It's a neurodevelopmental problem, usually impairs social interactions. There's verbal or speech issues, and there's certain behavior patterns that are going to occur. Typically, parents and or family members are going to notice something is just kind of off or not right by age 3. When I was coming up, they had no clue where autism came from. When I was learning about it, it was like, we don't know. It's kind of scary because we don't tell you what to prevent. However, I have long said, and I'm glad it's in the literature now, that it could be a genetic predisposition or it could be exposure to hazardous substances during pregnancy. So it could be drug use or it could be certain prescription medications. But again, here in the US, we don't do research on pregnant women and children. So we just are guessing at this point. The thing with autism, though, is that even though they have these profound disabilities and these social impairments, there's usually like one thing they're really, really good at. So my husband actually works with autistic children. In the high school, we had one that could hack any email account and email whoever they wanted to, hack social media accounts. This kid was a genius when it came to security hacking. We have another one that is exceptional in math. I mean, they just have one area that they are super rock stars in. So assessment findings from the social aspect, we find that they don't seek comfort in hug or physical touch like most children do. They don't have social play. They typically have very limited, if any, peer relationships. And quite frankly, they don't care or acknowledge or even recognize that other people are around, and certainly not the feelings of other people. For speech wise, it's either lack or impaired. They could be a monotone voice, and they have nonverbal communication. Very oftentimes, these patients may even be nonverbal. Behavior, they tend to have no imagination. They're preoccupied with certain objects. In today's modern technology, some of our autistic kids love iPads. They're just enthralled with videos on iPads. Sometimes they can be self-harm behaviors. They have to have a routine. If you mess up their routine, it's a bad day. Like, autistic kids have to have the same thing day in and day out. They don't like change. And then they could have repetitive body movements, and these things could be rocking, which is not self-harm, or they could like to bang their head on the wall or slap their foreheads over and over and over again. So repetitive behaviors are not uncommon. Next, we'll move on to failure to thrive. And basically, this is just simply defined as an altered physical growth and development. This is the last one. Yeah, I thought so. It is defined by weight and height below the 5th percentile. So when they're doing the growth charts and the height charts and all that fun stuff for kids, they find that these kids are below the 5th percentile. What we find is they tend to be withdrawn. Of course, they failure to grow because failure to thrive. They often have developmental delays and eating disorders. And so really, when it comes to FTT or failure to thrive, of course, fluid and electrolyte monitoring, nutrients, those are all big things. The other thing is, in order to develop healthy eating patterns that help them grow and mature and meet their milestones, requires a structured feeding environment. So this cannot be a family that's on the go and on the fly and whatever happens. This has to be pre-planned, very structured feeding environments in order for this child to thrive. And that is it. So make sure you like, comment, or share if you like content that you received, and I will see you guys in the next concept.